Okay. Well, thank you very much, Dr. Navta, for inviting me for this talk. I think this case blends very nicely into what Dr. Sujata has said. And, no matter where you are in practice, you may not be a refractive surgeon, but you can certainly encounter a case which has a complication, infective complication following the refractive surgery. And I think the best learning is through cases. So I'm going to just go with the case and give a few caveats in the end. So this was a 38-year-old lady, and she presented in October 2020, and she had diminution of vision for about 6 weeks in the eye. So it was not painful; it was painless and progressive, and she had some foreign body sensation in the past, off and on. On close questioning, she did give history of very minor fingernail trauma. She considered it trivial and ignored it, did not seek any treatment. She did give history of bilateral uneventful LASIK, which was done almost 13, 14 years ago. Her vision in the right eye, it was examination showed a LASIK scar. Left eye improved to 6/9 with a very minor correction. So she was doing fairly well on this count. However, when we examined her on the slit lamp, there was a huge island of epithelial ingrowth, and we can see the margins. You can see those little islands coming off it. They indicate that this is a progressive epithelial ingrowth, and we need to do something about it. A close examination of the margins of the LASIK scar. So this is something which you should always keep in mind to examine carefully. There was an irregularity. This indicates that probably the LASIK was not very smoothly done at that time. We did do an ASOCT, it revealed some amount of scarring and a huge epithelial ingrowth. And the pentacam also revealed an irregular cornea, which is what was expected. So we planned this lady for a LASIK flap relift and removal of the epithelial growth with other adjunctive treatments, including mitomycin C or alcohol or PTK. Patient was at that time reluctant. She was somewhat psychiatrically, I felt a little bit abnormal. She was alone. We kept her under observation. She said, I want to be under observation, come back. So she disappeared, presented after a month. Now, this was the presentation after a month. So just imagine, this is a nice, neat island of epithelial ingrowth. And she comes to us with a small island of infiltrates, corneal infiltrates, and there is also hypopyon. But this was not staining on fluorescent staining. Now, again, taking a close look at this eye, we could see that this irregular flap was actually a little bit more prominent. And also there was an area of corneal edema, which is a kind of opacification of the cornea in the lower half. And we could see on anti-segment OCT that there was presence of some infiltrates and also the infiltrates which were involving actually the full thickness of the cornea. So we made a diagnosis of the post-LASIK epithelial ingrowth, which was complicated by infectious keratitis. Now, the question is what to do with this kind of a patient. Now we have dilemmas. We questioned her again and again. Was there a domestic violence, some domestic trauma, somebody hit her? And she denied any kind of trauma. So spontaneously an epithelial ingrowth converting after 14 years of LASIK into an infection is something which I have not come across in my practice. The main question was to lift or not to lift, and we were looking at medical treatment versus flap lift, or to take a scraping and wash, which is actually what is advised and should be done. And but if you take a close look at the OCT, I think these are situations where the anti-segment OCT is absolutely crucial. We could see that the infiltrates were actually intruding into the anterior chamber, and we know that if you lift a flap, one, it can induce some kind of a refractive error. Secondly, if the infection is deep and doesn't respond, it can actually lead to more spreading of the infection in this case. So, with the very for some apprehension, I did start her off on broad spectrum, antibiotic therapy, and which included levofloxacin, which is a newer antibiotic. It has an excellent broad spectrum coverage, including with the gram negatives. We did give her fortified amikacin, which we know is also useful against organisms like atypical mycobacteria. although I find that the incidence has gone down since we have shifted to femtosecond lasers, and we did give 45 vancomycin drops. I do like to give some kind of anti-glaucoma drops, as Dr. Sujata has well highlighted, because there is an element of secondary glaucoma in patients who suffer from infective keratitis. Atropine should be given. It's to stabilize the blood aqueous barrier, and it's nice cycloplegic, makes the patient feel better, with lubricant drops. And we managed to convince this lady to get admitted, and we kept her under very close follow-up. So we could see that, within about 72 hours, the hypopion, which is a very good indicator actually, when we are treating these patients of infective keratitis, look for the hypopion. If it's decreasing in size, a very good indicator that he's responding. So we could see the hypopion is gone, and we can see that edges of the infiltrates are getting organized. So this is another important indicator that patient was responding to antibacterial treatment. And day 6, we could see actually that there is even more of a resolution and compaction of the infiltrates of the cornea. Along with that, if you see the adjoining cornea, you can see that it is become clearer, the edema is lesser. So the second question, again, which was addressed by Dr. Sujat, is would you initiate topical steroids? And there is no doubt that there are some situations, including fungal keratitis, and maybe in other situations where it might worsen nocardia. So, for example, in the steroids for corneal ulcer trial, they showed that it works well in culture-proven bacterial keratitis, and in nocardia keratitis, we should, it's associated with a worse outcome. So we should withhold. There are a couple of other, studies. They show that the area of healing has improved in the steroid-treated group versus the non-steroid-treated group. Now, she went back again, and she's now presenting with this kind of an appearance. We can see that there is a little bit of an epithelial ingrowth which is still present, and some scarring which is there. And this is the intersegmentosity of this patient. And we have called her again. She didn't turn up for the last 1 month. So if you look at post-LASIK infective keratitis, very large series has shown about 0.035% of incidence after LASIK surgery. And we should keep in mind various risk factors, including blepharitis, lid involved. Look at the eyelids of the patients, pre-existing dry eyes, history of previous healed keratitis, especially the hepatic keratitis. These things are very important. The any MGD, previous corneal surgery. So these are all risk factors, including some intraoperative risk factors. So you should be obsessive about isolating the lead margins. Where you take care that they're well isolated, they don't come into the operative field. Avoid contaminated surgical area instruments and excessive tissue handling and epithelial defects. Why I'm saying is because most of the refractive ORs are distinct from the routine ORs. Therefore, the practices of those ORs may not be as stringent as the routine proteins. Post-operative factors, excessive use of steroids, if you look at improper use of antibiotics, and exposure to impure water, trauma, delayed epithelialization. So you should keep these patients under close follow-up, and at the same time, you should be aware about the main organisms which are causing these kind of infections. So it has been reported that surface laser ablation, including PRKs, they have a higher incidence of infection compared to basic patients. And also, if they present early, that is within the first 14 days, staphylococcus, especially epidermidis and streptococci, are fairly common. And if they're delayed, fungal causes in India, I think fungal would be an important cause. Mycobacterium, which was mainly associated with the use of microkeratomes, nocardia, acanthamoeba can occur. Fungal keratitis, viral keratitis may recur in these patients, and we have seen a few patients after refractive surgery who have got triggered the episode of viral keratitis. We should closely look at the clinical features, which was handled by the previous speaker, and look at the location of the infections. They can be unifocal, multifocal, they can be progressively increasing in size, and interface infiltrates are the most common presentation. Why this is important is many times they are mistaken for a diffuse lamellar keratitis or sands of Sahara, which is an inflammatory reaction that requires steroids. And that is the reason many of these patients are exposed to frequent steroids, and then what happens is that it turns out that they actually had some kind of an infection. Other presentations where we can have surface ulceration, we can have anterior chamber infiltrates, really endophthalmitis, and the flap margin and secondary stromal involvement can happen. There was a patient I saw many years ago, and this patient had infiltrates in the flap and the adjoining cornea at three areas in both the eyes. And we investigated this patient, and what it turned out was that the marking pen which the surgeon had used, it was kept at that time in a formalin chamber, and that pen had a pseudomonas contamination. Patient got a pseudomonas ulcer in both the eyes. So preventive measures, if you look at that, preoperative, intraoperative, and postoperative, rule out dry eyes, stabilize the ocular surface, make the ocular environment friendly to the healing, give warm compresses, doctor systemic antibiotics. Many of these patients, they are conscious about it. They have acne, they have some kind of a, so they are, many of them are on already on treatment, and we should just look at that as well. Yeah. Intraoperatively, handle the flap carefully while lifting. Don't avoid touching the lid margins with your instruments. Use separate sets of sterile instruments, fluids, and ensure sterility. There was one recent survey which has come in January 2021 in JCRS. Now, what they said was they studied French surgeons. I think this survey was carried out, they 400 surgeons. And they noticed that many of them actually don't even wear gloves, and many of them were not wearing any sterile equipment while they were operating. So that's not done, especially in India. And 85% were not giving 3 minutes following beta demonstration. So there are some practices, healthy practices you should incorporate in your practice. If there are epithelial defects, of course, restrict steroids, give nice antibiotics, including, I would say, even levofloxacin, which has come recently, because this is a situation where you can't afford an infection. Be stringent in your follow-up. Don't forget about the patient after a few days. So the recommended is at least 3 in the first month: day 1, day 7, and day 30. And look for, have nice examination of these patients. Avoid contaminated water in these patients. And so if we treat well, many of these patients actually end up with a vision of better than 20/20, up to 60%. This patient also ended up with a vision of 6/6 on the last one. Thank you very much. I'll be happy to take any questions.